Good evening, everyone. We welcome you all to the another webinar session about rehabilitation lung transplant reality. As everyone know that pulmonary rehabilitation, it significantly reduces the symptoms, improves the exercise tolerance, and improves the quality of life, especially for patients with end-stage lung disease like chronic obstructive pulmonary disease, interstitial lung disease, etc. But however, many of a patient that comes to the pulmonary medicine OPD, we know that they are very scared or they are not sure about how to go ahead with the rehabilitation program or how long to undergo. So there are many stigmas in the rehabilitation. So we thought we'll address this scenarios with our experts. So we have experts from two different perspectives. One is how to optimize rehabilitation, especially for patients plan for transplant, and what are the rehabilitation that they should take care after lung transplantation. So the first speaker is Mr. G.N. Nagasumanth. He's our Chief Physiotherapist of Yashoda Hospitals, Hyderabad. Along with him, Dr. Vasavi, who is a rehab in charge of Yashoda Hospital, Secunderabad, will be speaking about the perspective on optimizing the rehab, especially for patients with an end-stage lung disease prior to transplant. Over to you, sir. Sir, your audio is not clear, sir. Audio. Sir, audio, sir.
Sumant, sir, unmute yourself.
Yeah.
Yes,
is that fine?
Yes, sir. Now your audio is fine, sir. We can see the slides.
Yeah, fine. Yeah, fine. Is that fine, sir, now?
Yes, sir.
Yeah. So I'm Sumant, Chief Physiotherapist, Yashoda Hospitals. So about lung transplant. So we'll be seeing our cases in our hospital. We'll be doing rehabilitation as well as post-op rehabilitation. So when it concerns with lung transplantation, is an elective treatment for individuals with end-stage chronic respiratory diseases, whose life expectancy is higher with this intervention. The pulmonary rehabilitation, as Dr. Vimi sir was telling, there are a lot of doubts, stigmas are there among the people. So in reality, the pulmonary rehabilitation is a very safe approach for the patient with lung disease. Okay, and it is very important post-operative also. So exercise, despite of patient constrained reserve lung volumes, okay, the pulmonary rehabilitations ensures that the patient can stay fit and can move the most of his existing lung function. So most of the myth is the patient, the people surrounding the people around the patient, they say as their lung function is impaired, you are not supposed to move much, you will get dyspneic, you will fall, and you tend to take a lots of rest. So this is the biggest problem, and we need to counsel the patient to overcome all this. So when it comes, the pulmonary rehabilitation definition is, it is a comprehensive rehabilitation based on thorough patient assessment, followed by a tailored therapies to the patient. I am repeating, it is a tailored therapies to the patient that includes but are not limited to the exercise training, and it includes the education of the patient, behavioral changes designed to improve the physical and psychological condition of the people with the chronic respiratory disease. Here, The teaching component program is very important. In our teaching component program, we'll be along with transplant surgeons, along with pulmonologists, along with nutritionists. So we'll be educating the patient, okay, and we will make the patient will be the in charge of his breathing rather than having the breathing control over him. So in this, the patients need to understand this very clearly, the vicious cycle of dyspnea. So in this, what happens is in any lung function, in any lung diseases, there'll be lots of impairment of lung function. When there is when there is an impairment of lung function, the patient will tend to have lots of musculoskeletal compromise. When there is a musculoskeletal compromise, so here the one thing we need to understand is in case of musculoskeletal compromises, the patient tends to limit his function. When the patient is having the less blood supply to his peripheral muscular system, they tend to develop some trigger points in their muscle groups, for example, in calf, thigh, whatever. So when the trigger points are developed, they are more prone to give a pain. When the pain comes, again the patient mobility is limited. So the patient mobility is getting limited because of lung compromise as well as musculoskeletal compromise. So with this, the patient tend to decondition a lot. So when the patient tends to walk, he tends to feel a dyspnea. When the dyspnea comes, the patient immediately he will get a fear and immediately he enter into an anxiety. So when this cycle continues, when we enter into the anxiety, again the patient will be bound to bed or he is bound to chair. This vicious cycle will be keeps on continuing. So as a physiotherapist, so as a cardiopulmonary physiotherapist, we need to boost up and I need to analyze the case properly. So whether he has got muscular component involvement, to what extent his musculoskeletal component is involved, his pain is alarming him to take much rest, and whether his lung compromise is dominating much. So I need to address both. I need to educate the patient. I need to overcome the fear of the patients. So to break this vicious cycle, breaking this vicious cycle is very, very important. We need to analyze where the patient is getting a problem. So the components of pulmonary rehabilitation. So here, being in pulmonary rehabilitation, not only a physical therapist will be taking part, no doubt your pulmonologist, transplant surgeon, okay, and a nutritionist, physical medicine doctors, okay, a psychologist. So these are all will be into, we work as a team. Being a physical therapist, my role is to emphasize a lot on exercise training, endurance training, respiratory muscle endurance training, respiratory muscle strength training. Okay, and I need to get a support from definitely from psychologists for psychosocial supports, and from our dietitian for nutrition supports. And based on all these things, we'll be checking some outcome assessment to explain to the patient so that the patient can move further. So our assessment includes, so our physiotherapy assessment is based on primarily the medical assessment, okay, medical assessment and psychological assessment and nutritional assessment. In medical assessment, there'll be a quality of life assessments, a dyspnea scale assessments, in diagnostic assessments. So before planning our rehabilitation program, we'll be considering the pulmonary function test, cardiopulmonary exercise testing, and ABG test. So based on this, I'll be planning my rehab protocols. So either prehab or rehab, I'll be following these things. In psychological assessments, definitely the patient should be out from anxiety and depression. So the family members has to support the patient, and the patient should be in a position to understand what I am expecting. If the patient is coming to me with a very high expectations, I need to low down his expectations, and I need to explain him clearly when the outcome measures will be expected. when the patient is in the other way, when the patient is coming to with a very low expectations, it is my duty to boost up the confidence. I need to give the examples of other patients. I need to show some videos of the other patient, and sometimes what we do in our department is we'll make this patient to talk with other pulmonary rehabilitation patients who's undergoing the treatment. That is the biggest thing. So whatever we tell, the person never develops that what confidence. When the co-patient tells, when the other patient talks about the importance of rehabilitation, how he is improving with the rehabilitation, how he has overcome with the fears, the patient will immediately turn out to be our patient. So when it comes to a physiotherapy assessment, here I'll be considering a lot on their respiratory assessment and musculoskeletal assessment. So definitely I'll consider the range and strength of the muscles. When it comes to one diagnostic assessment in our department, I'll be doing this 6-minute walk test. This 6-minute walk test is a very, very simple test. We'll be doing this with a 6-minute fitness machine, with fitness equipment. In this, we'll be taking the demographic data of a patient. Demographic data of it. It's a very short video. Just you see the video. What are the parameters we are taking? How we are testing? We'll record everything: their blood pressure, their heart rate, their oxygen saturation, and everything. And we'll make the patient to move for 6 minutes. We'll make the 6 minutes, and each lap is for 30 meters. Each lap is for 30 meters. Okay, in this, we'll be making the patient do. If the patient is feeling dyspneic in between, he can take a rest. And if you want to continue the test after some time, he can get up and he can walk around. So after completing this test, so this is the one test report I have kept. This test report by the Janardhan patient of 47 years old. He's come to us the department with a 5 liters of oxygen support. Okay, so according to height and weight, he's predicted height, weight, and age. His predicted distance is around 587 meters, but he could complete only 6 to 10 meters. That is only the 35% of what he's supposed to do. In this 35%, that is definitely it's a low. So my exercise prescription planning should be very careful. That means this test will say me to start exercise program with a very low intensity levels. So along with this, we have to take his musculoskeletal assessment. If he has got any musculoskeletal pains, I need to address those too. So exercise training. Okay, the considerations we'll be doing is endurance training, interval training, resistance training. Endurance training, it can be an high intensity training or low intensity training. If the patient, so before I have explained the 6-minute walk test, if the patient could achieve more than 70%, I can think of high intensity training under supervision. The high intensity training can be given in between somewhere 20 to 60 minutes. Directly, we can't go to 60 minutes. Definitely, we need to start at 20 minutes and gradually we need to progress. We can progress till 60 minutes. So in endurance training, if I get only 35% or 40%, my choice of treatment is not high intensity training exercise. My choice of treatment will be low intensity exercise, and that should be under strictly supervision. So once the endurance training, once the patient is comfortably doing the endurance training, though he is doing high intensity endurance training, we should not prescribe any high intensity exercise training without supervision. So whatever home program we are giving to the patient, that should be the low intensity training. That should be a low intensity training. Next comes interval training. Interval training means we should give a rest between the training activities. In interval training, if the patient has achieved a good amount of percentage with 6-minute walk test, I can give an high intensity training, but I should give a proper interval rest between that. So when the patient is getting in small, low percentile, I should start with a low intensity interval training. So it's not mandatory that for each and every patient should receive endurance, interval, and resistance training. If their percentile is very less, I should start them only with an interval training. As they are progressing, I can slowly add them on endurance training. So when they're doing good with interval training and endurance training, my choice of treatment will be resistance training. In resistance training, I always start with a low intensity exercises, so low or low resistance exercises that can be with your weight bands, stretch bands, tubes. So once the patient is comfortably completing the low intensity resistance training with whatever the repetitions I have prescribed, then gradually I progress to next level. Gradually I progress to the next level in the resistance trainings. So when it comes to physical training, our main key success for our predicting the outcomes in our physical training should be, we need to consider these three things. One is the frequency, intensity, and specificity. So initially itself, I said, it is not like in orthopedics, we'll be prescribing the set of exercises. You're supposed to do this set of exercises. So the frequency, intensity, and specificity changes from patient to patient, and exercise protocol will be completely tailor-made. The frequency, usually 6 to 12 weeks of pulmonary rehabilitation. Okay, 6 to 12 weeks, the patient should if you want to see any benefit out of pulmonary rehabilitation, so the patient should he should undergo 6 weeks to 12 weeks of program, 12 weeks of rehabilitation program. Then only we can expect the outcomes. Likewise in musculoskeletal rehabilitation, you can't expect the result in 3 or 4 days or 1 week or 2 weeks. It's mandatory to undergo 6 to 12 weeks. This is the first thing we educate the patient. To what extent? So the patient expectations are, so when I will improve. So if the patient wants to improve, he has to undergo 6 to 12 weeks or program, and supervised sessions should be for 2 to 3 times per week. So once the patient is getting a supervised sessions, the low intensity training will be telling the patient as a home program, and session duration will last for 40 to 60 minutes. And it's not mandatory that we stop exercise at 60 minutes. Sometimes we progress to 1.5 minutes, because most of the patients with the low endurance, those will be coming with us. So when we start with an interval training, so they want rest gaps a lot in between. So we allow the patient to take lots of rest gaps in between, and gradually we will be improving their strength and endurance. So when it comes to intensity, it will be all dependent upon our 6-minute walk test. So as I explained you earlier, based on 35% or 70%, based on their percentage, and based on their previous physical activity levels, and based on their musculoskeletal compromise, I'll be deciding their intensity. That intensity could be high intensity, low intensity, resistance, or interval trainings. So I'll be deciding based on my 6-minute walk test assessment, and whatever the report which I got from a pulmonologist based on their quality of life, as I explained you earlier, their PFT testing, I'll be deciding. Next, it comes here specificity training. This is very, very important. As the research says, targeting a large muscle groups will give you a effective outcomes than targeting a small muscle groups. So in this, usually, we have a good large muscles in our lower limbs. So usually our target will be quads, hamstrings, glutes. When it comes to upper limb muscles, our target will be the biceps and triceps. So these groups will be training a lot for more benefit of for more good outcomes of your pulmonary rehab. So when it comes to strength training, so we decide the strength training based on repetition maximum. For example, the patient can maximum lift a 5 kg of weight. That is the standard, means I will give only example I am telling. Okay, so I'll give startup only the 50% of one repetition maximum. But if the patient can lift 5 kg weight, that is the maximum that they can lift. So only I'll go with the 50% of that. That is 2.5 kg. 2.5 kg weight I'll start. I can progress till 85%. So I can give 2 to 4 sets and 6 to 12 repetitions based on the patient fatigue and pain levels. I'll be stopping. So in clinical trial, they have done some studies. They have done some studies on our experimental group and control group. So experimental group, they have given They have given low intensity lower limb exercises, and for control group they haven't given anything. So outcome measures, they have found it, the people who have received low intensity exercises, they could walk comfortably. They could walk comfortably, and they had lots of physiological adaptations due to exercises. So this is a physiotherapy unit. So this is a patient of ILD case with. So he's on oxygen therapy. Is a prehabilitation. He came with us, and he has got a beautiful history of doing gym workouts. So immediately he has progressed to the strength training. We started with a resistance training exercises with the bands, and immediately progressed to the dumbbells, and eventually is progressed on. Eventually progressed with a he has progressed with our resistance training unit. He has progressed to our exercise training unit, and with this exercise training unit, he has, whenever he is doing exercises, okay, definitely in this photograph is not the same patient who is doing an exercise training on resistance training mission. Okay, whenever he is doing on this mission, okay, so he's on oxygen oxygen therapy. He's continuously on 2 liters of oxygen therapy. So this is our resistance training unit. So we'll be targeting larger muscle groups: quadriceps, hamstrings, latissimus dorsi. Okay, and this is the best suited for the people who has got less 1 liter or 2 liter or 2 liter or 3 liter of oxygen therapy, and who has got a previous history of exercise training. They progress well within strength training. They really do best. So when it comes to an endurance training, it can be an low intensity high duration trainings or high intensity low duration trainings. Usually we'll go with 60% of maximum workload heart rate, and the endurance trainings we can permit the patient till 30 minutes. So for upper limbs, we'll be using the active passive trainers, cycle ergometers, elastic bands, and stretching bands and weight cuffs. When it comes to your lower limbs, for endurance training, the same thing. We'll be using the stationary bikes. In stationary bikes, we'll be offering resistance, increasing the resistance. Treadmills we'll be using, and we'll be using the active passive trainers to improve the endurance of a person. So for endurance training, the best modes are cycle and treadmill. So in cycle and treadmill, as we mentioned from beginning, we are talking, these people will be having a lots of fear. So who has got a lots of fear, the first we may take them to a cycle ergometer or recommend bikes. When they start doing, and we'll be showing them how they are improving, and gradually when they get a good truncal balance, when there is ease of pain, slowly they will be progress them to the treadmill trainings. Slowly we'll progress them to the treadmill trainings. So when it comes to a specific respiratory muscle training, so it all depends upon our PFT report, maximum inspiratory pressure. If the patient, we can progress till 60 to 70%, but if you want to train specific training to the inspiratory muscles, here we need to start with a 30%. Here we should have a proper examination. Here we need to check properly the diaphragmatic activation, intercostal activation, whether the patient is using his accessory muscles. When the patient is using, if he is using his accessory muscles, scalene muscles or sternocleidomastoid muscles, so we need to calm down those muscles, and we need to properly activate intercostals and as well as diaphragmatic muscles. These people, mostly they complain of intercostal pains because they develop a lot intercostal triggers. So we need to release the triggers. We need to improve the activity of intercostal muscle activity, and we need to ensure properly retrain the diaphragmatic activation. So with this, the patient accessory muscle activation will be reduced. When these accessory muscle activations are reduced, so definitely by ease, the maximum inspiratory pressures will be improved drastically from 30% to 70% we can achieve. So for training the inspiratory muscles, we have got a inspiratory muscle trainers One is threshold device and power device. These are the two devices. First, we'll start with a threshold device. If the person is doing good, eventually we will progress with a power device, power mode. So education of patient is very, very important. So we should teach a proper breathing patterns. So here we need to teach proper pursed breathing, proper activation of diaphragm, breathing exercises, and energy conservation techniques. Pacing of activities is very important. Breathing control during movement is very, very important. So whenever he is doing any upper limb activity, we always encourage a patient. Suppose if he's lifting two hands up, so while lifting both hands up, we'll encourage a patient do inspiration. When he's taking down, expiration. We should synchronous musculoskeletal activity with a respiratory activity for a beautiful outcomes. So the body positions and mechanics are very, very important. Some compromised position, the patient tend to sit in a slouched position. When he's sitting in a slouched position, he's compromising he's increasing his intra-abdominal pressure, he's pushing his diaphragm up, his thoracic cavity is being compromised. So we need to always encourage a patient to sit erect to increase their lung volumes, to increase the lung vacuum. Then only your proper diaphragmatic activation will be there. So this is our post-op case. This case recently got operated, lung transplant. Immediately we took her to our department. Okay, we started. So immediately we took her to our department. We started with basic exercises and strength training exercises. We started with a minimal 1 kg free exercises. We have got a very beautiful department. They can see through outside. Okay, this is a very, very important thing. Once the patient comes out and when he sees the outside world, psychologically they become very active and they start interacting. And in our program, okay, we make it playful. We'll make it playful. Okay, playful activities. Okay, to motivate them. So motivating is the biggest concern in this program. So this post-op case, early ambulation, we started with the back support and gradually we'll wean up the back support to improve the truncal balance. And we get them to the department. We'll start to make them to sit in a recliner. It is very, very important when they come to department. Definitely transplant surgeon, concerned pulmonologist, anesthetist, they'll come to the department to ensure the safety of the patient. So based on their inputs, we'll be motivating the patient and we'll be starting our pulmonary rehabilitation. So this patient immediately after it's a day one, they have come to the department, we'll make them sit on the recliner. She's seeing the outside world. She just psychologically, it will be boosting them a lot. So this is the case. Okay, it's the 11th day. We motivated them to stand up with a support. So they could stand up. So it will boost their morale, confidence. Okay, our therapist will be reassuring, will be giving a confidence continuously to the patient, and will be talking the success stories of the past patients. So they really cooperate well. So just without talking to the patient, just to keep on treating the patient, definitely it doesn't give a good effective outcomes. Okay, interacting the patient, telling the success story, and anesthetist, pulmonologist, and transplant surgeons will be continuously involving for a better outcomes. So this is our department. It is very well equipped with a good oxygen therapist. You can see from the beginning. So we have got a good oxygen therapy. Oxygen, the continuous flow of oxygen support will be there in our department. Here we have got an endurance training unit, strength training unit, and some playful unit. And for biofeedback, we have got a good mirror to see the patient can see by themselves. On the other end, you can see the good metro view, airport view, so good of greenery. So for improving the psychological component, because at the end, the psychology, we can't deny, the psychology plays an important role for getting a very good outcomes. Thank you, sir. I'm done, sir.
Okay. Thank you, Suman, for the nice presentation. I think from a physiotherapist point of view and from a doctor point of view, I think there are many hurdles for a successful rehabilitation, and I think we both should work together for the success. And it's good that you are educating the program which you are currently doing, and it actually creates a lot of motivation, especially the patients who has undergone a transplant and who was in the ICU for a long time, and suddenly coming to a rehab program, seeing in the outside world, actually it creates a lot of impact. From the example of the patient which you have shown, we can steadily see the progress of that patient day by day in terms of rehabilitation, her motivation, and finally seeing them at least walking or standing with support on the daily rounds. It creates a big impact. So before going to the next speaker, Suman, I have one doubt that I wanted to ask you. Like, so what are the challenges that you face regularly, especially for the patient that is planned for transplant? Like one or two sentences. So if you can tell me what are the main challenges, so that we are very clear.
Yeah, Vasavi will explain you, sir. She'll be in and out with the patient.
Yes.
So the main challenge which we will be seeing during the prehab session, sir, it will be the patient cooperation and understanding of the patient, like how much is the duration they will be taking to get the good outcomes. At least it should take a minimum of 6 weeks to see a proper outcome. They have been explained during the treatment plan, which has been assessed and given to the protocol of the patient. After that, they have to follow up to the department and continue as the adaptation to the exercises. They have to long-termly adherence to the exercises is also one of the major challenge. And there are few patients, it's not that everyone, few patients who doesn't understand the usage of oxygen levels while the exercising. They don't know the they have to increase the oxygen while exercising because the exertion is more and they'll get dyspneic sooner. So these all the challenges, though it has been taught to the patient while educating them, follow up gives them more adherence and knowledge regarding this. So these are the main points which have to be received by the patient.
And one other small doubt is, does that patient need to come every weekly, once or twice to a rehab unit, or you teach them the exercise and they practice at home? How does it work for a good rehabilitation program?
Sir, I'll explain this, sir. So here, sir, biggest challenge is the psychological components, sir. So here, sir, we have seen quite a few patients who are doing at home. Really, we don't know they're properly activating their muscles. So because the diaphragmatic activation is the biggest challenge, sir. And axillary muscles they'll be using unless and until I give a continuous feedback. Okay, they don't learn the proper breathing pattern. So at least for few sessions, sir, either they should come to us or our trained physical therapist can visit them. They should be in some supervised exercise, sir. And we have seen, sir, one patient motivating the other patient. If one patient is undergoing rehabilitation now, so they can educate the other patient well than us. Yes. Whatever we tell, sir, the patient will tell, okay, he's a doctor, he is telling. So yes, once the patient tells his success story, when he has come, how he is and how he is improving, it matters a lot, sir. It matters a lot. Once the patient learns the proper activation, sir, and he can do exercise by himself. Otherwise, if we teach only once and send the patient, sir, there are researchers, the non-adherence towards the exercise will be more. So to create an adherence, so the patient has to understand, the patient relatives has to understand, then only the outcomes will be better, sir. And minimum they need to be, really we don't know in-house they are doing properly or not.
Yes. Sure. I think that that's a good advice for especially for patients who is considering a rehabilitation program for an end-stage disease, about how frequent they should visit and other thing. So now we'll go to the next speaker. Next speaker is...
I have a question, sorry.
Yes.
Ma'am, do you have any tele-rehab services?
Yes.
Yes, ma'am.
So,
we are giving home rehab sessions,
No,
ma'am.
no.
Tele-rehab sessions,
Tele-rehab.
tele-rehab sessions,
Yes,
and
ma'am.
departmental sessions, ma'am.
Ma'am, most of our clients, ma'am, who is coming from outstation, they'll take tele-rehabilitation. We will be talking to them. We'll be talking to them on video calls and we'll be educating them, ma'am.
so they note down the oxygen levels and all when they exercise and let you know.
Yes, ma'am. Yes, ma'am. Ma'am, first at least 3 sessions may we require, ma'am, to understand their oxygen level, because biggest thing is their fear and anxiety. When they're doing exercise, they'll get some dyspnea and immediately they will become what, ma'am? They'll get into anxiety and they develop non-adherence towards exercise. So for that, they need to overcome and they need to understand the concept, ma'am.
Okay, nice hearing.
So coming to our next speaker is Dr. Lakshmi Nair. She's a consultant rehabilitation physician from Kauvery Hospital, Chennai. She was trained in Adelaide and she only worked to set up the cardiopulmonary rehabilitation unit in Kauvery, and she's a part of the Heart Lung Transplant team there. And she coordinates the inpatient and outpatient of the Heart Lung Transplant Rehabilitation Program. So thank you, ma'am, for considering our invitation and willing to join and our webinar. So Dr. Lakshmi ma'am will be telling us about the optimization of the rehab, especially for patients who has undergone a transplant and what are the challenges. Over to you, ma'am.
Thank you so much. Try sharing my screen. Are you able to see me?
No, ma'am, not able to see you, but your slides we can see, ma'am.
Can you make it possible to see me? You people can see me?
No, ma'am, your photo is not clear or it's not seen.
I think I've shared it. Okay, so I'll be talking about post-lung transplant rehabilitation. So I'm Dr. Lakshmi. So I would like to thank Yashoda Hospital first of all for giving me this opportunity. So I really like your heading, is it a reality, the rehabilitation in lung transplant. Actually, the rehab as such, I would like to ask whether is it a reality in India. I'm not asking, WHO is asking this question, and they have set up Rehab 2030 as a goal for to establish rehabilitation in India in a better way. The cardiac rehabilitation in India was surveyed by the ICC PR. There was a global audit where there was a online audit, which all centers are doing a proper structured cardiac rehab program. Only few centers, but only 23 centers were there for the whole of India. So there's a huge unmet need for proper structured rehabilitation program in India. So I'm part of the Kauvery transplant program. So as doctor explained, I've done my rehab training in Adelaide, where I could do some inpatient rehab program for the cardiopulmonary patients as a part of the elderly care rehab only. But I'm learning more of transplant rehab after coming to Kauvery. So we have been running this program since nearly 2 years, not 2 years yet. So rehabilitation, we have heard from Sumanth, he has given a nice description. And rehabilitation actually starts post-surgery. Till surgery, we have many limitations, but the patient's participation in the rehabilitation program would definitely decide how good the outcome of surgery is. A good rehabilitation program is very essential, and improvement in the 6-minute walk test we target before we take the patients for surgery. So post-transplant rehabilitation is more rewarding, I feel, in the sense of we can immediately see the improved quality of life of the patient. They come out of the oxygen support. It's easier to achieve our goals once they are post-transplant. So, but there are a lot of challenges in rehab. Post-transplant rehab, the endless challenges, cost of pain, infection, rejection, anxiety, depression, DVT. The numbers are endless, but challenge should be accepted in a positive way to have better results. Side effects of medications. You should be able to educate all this to the patients. So what are today's learning objectives? So how to set goal at each stage of post-transplant rehab. And I'll give you practical points to run a cost-effective, evidence-based post-transplant rehabilitation program. So studies say that there is a study by Sunita Mathur, and it says that there is reduced exercise capacity may be persistent for up to 3 years post-transplant. Peak exercise capacity is decreased to 40 to 60% up to 2 years post-transplant. The muscles have become modified due to the long-standing disease process. The muscles have become used to the less oxygen supply. The heart and lung is not perfect, and the muscles are not getting enough oxygen. So the muscle structure changes. There is a more reduction in type 1 fibers. Type 1 fiber, for pre-transplant fracture, there is a reduction in type 1 fiber. Somebody called Zhao Nivari that did a study on they did a biopsy on the muscles of the transplant patients and analyzed how is it different from other normal patients. So they could see that there is a reduction in type 1 fiber. The mitochondria as such has changed. It has adjusted itself to anaerobic metabolism. So more of anaerobic metabolism is happening to generate ATP. The baseline ATP level itself was low, and more enzymes are of anaerobic type, low aerobic type of enzymes. All these changes are happening within the mitochondria of the muscles. So it's the fine structural level change that is inside the skeletal muscles that is not reversible in 1 or 2 days. We can't expect the patient to attain full muscle capacity. It might take years to gain back that. Post-transplant factors also contribute. The muscles can go into a catabolic state, self-destructive state. It can be due to the sepsis, immobilization, and medications. The post-transplant steroids and the immunosuppressants will add on to this muscle wasting post-op. So the muscles of the transplant awaiting candidates or the post-transplant candidates tend to have a earlier, when you do a CPET machine analysis, the VO2 peak, they tend to have early lactic acidosis. That is what the study shows. And the muscle structure, the fat content in the muscle and all is comparable to the a COPD patient. In this study says that the fat structure is comparable to a COPD patient, to a post-transplant patient, but there are isometric contraction of the quadriceps alone was different. That is a finding from this study. So as such, what you understand is the structure of the muscle as such is different for the transplant patient. So it's more difficult to train them when compared to any other normal post-op rehabilitation. So we follow the American Association of Cardiovascular and Pulmonary Rehabilitation protocols. This is a good journal which is really accessible. You can have a look. This is the protocol that they suggest. The pre-transplant program, the post-transplant program, they've divided into 3. Acute hospitalization, early post-transplant program, and long-term program. So the acute hospitalization is in the ICU and what is early mobility, progression to independence. You should not miss this factor. Their independent transfer, walking, self-care, daily activities, you should stimulate them to do by themselves. should reach up to stair climbing. Exercise training, the usual pre-rehabilitation type, aerobic resistance, flexibility exercise, oxygen titration, slowly weaning off oxygen. Post-transplant, 1 to 6 months is the period when we suggest them the aggressive post-transplant rehabilitation program as such. The usual, what Sumant was saying, FITTP, the frequency, intensity, time, and type should be prescribed in a progressive way. So the patients can be of two types. So what Sumant showed was a complicated long ICU stay, those who are on tracheostomy, those who have the CPAP supports. So they tend to lose muscles. The longer they stay, they tend to lose more muscles. So for them, we might have to consider a prolonged period of rehab, a referral to inpatient rehabilitation program if necessary, a slower progression, but still taking into consideration the transfers, self-care, stairs. Slowly, we need to guide them, holding their hands. So exercise training is common for all of them. Post-transplant, more than 6 months, it's mostly community reintegration. So home and community programs. So it's just the maintenance of whatever we taught during the first 6 months. So we should be educating them on long-term being physically active, returning to work. That itself will improve the physical activity, or they can participate in group programs, sports, etc. So our model of care, we have a hyperacute rehabilitation program where I go inside the ICU and along with the physio and assess how good the patient is, and the physiotherapist will be giving therapy. So we usually request more analgesics so that the physio can do better mobilization. It continues in the acute care ward once the patient is shifted to the acute care ward. I'll be discussing in detail. And hyperacute rehabilitation, then we have the facility for inpatient rehabilitation. I think Kauvery Hospital is unique in the way that it has its own rehabilitation unit. It has a OT, speech, everybody working together in a multidisciplinary mode. It not only caters transplant patients, but other general rehab patients also are there. But we take good care of the sterile precautions and all while exercising the rehab patients. Outpatient rehabilitation, mostly we do it for pre-rehabilitation, and post-transplant, if they are willing to come into our center, we do outpatient rehabilitation after discharge home. Home therapy is mostly preferred by, we fail to convince most of our post-transplant patients to come back to our center. So mostly we send our physio home and do intense program for 3 months. If they are willing to come in, we start using the equipments to train them. So we'll discuss the goals during each of the rehab phases. Hyperacute rehab, while the patient is still in ICU. So our priority is secretion management. We should help the intensivist to wean off the supports. For this, the lung should, even if it's a new transplanted lung, there will be secretions. We need to clear the secretions better for a better lung expansion. So directed coughing technique is extremely important. They can use a pillow to support the incision site and assisting the expiratory muscles by giving pressure on the tummy, on the abdominal muscles, helps to expel the secretion better. Due to the transplant, there will be some amount of denervation of the lung. The denervation will contribute to a weaker cough reflex. So the secretions tend to get stagnant there, and any stagnant secretion will get infected, and antibiotics, this will go on as a cycle. So we need to cut the cycle from the beginning. So assisted coughing technique, and also just think about the mucolytic agents, and also what else? Secretion clearance. If at all they are on tracheostomy, then it becomes more of a concern. They will be used to this mouth breathing and the expiratory techniques, controlled breathing techniques through mouth. But we need to re-educate them that you need to breathe through your neck and not your mouth, and they can press on the tummy a little bit, making sure that the incision site is safe. So lung re-expansion, especially in the tracheostomy patients, diaphragmatic breathing exercise helps a lot. Keep their hand on the abdomen and ask them to take a deep breath, looking at the hand. Also, huffing techniques you can make use after taking 3 deep breaths in. You can ask the patient to huff twice. The pain management is extremely important to have good results. Always remember, mobilizing out of bed is the best chest physio. That should begin early, as Suman was saying. But for that, the pain should be managed well. We need to ask support from the ICU team. Reduce supports and ICU stay. By doing all this, we will be able to reduce the support slowly, and we will be definitely able to cut down the ICU stay. So postural stability, you need to start working from early time itself. Postural stability, the patient should learn to turn in the bed, learn to sit without support, slowly attempt sit to stand, and transfer to wheelchair, and then walking. While walking, don't forget to give them a walking aid. That will help to conserve so much of energy. And also sit to stand, try not to pull them up with the axilla. You can use the equipments you have, and by pulling, you are stretching the incision site and aggravating pain, and then they won't breathe enough if the pain is aggravated. So all this possibly, sit to stand will help to promote the quadriceps strength also. Some studies have shown that the quadriceps strength is one most decisive factor which decides the length of ICU stay. So if you can improve the quadriceps strength pre-operatively itself, that will reduce the ICU stay. So this is our post-transplant patient on day 4 post-op. She's being mobilized. She was mobilized to the chair. She's one of the patients who were mobilized to the chair early on the day 2 itself. She started walking by day 4. This is our physio instruction for walking her. You can see he's taking care of the tube well. She's still on oxygen, but only 2 liters. While sitting, she was off oxygen. So she had a post-op, excellent post-op progression. We could make her climb stairs before discharge, but she got readmitted due to rejection. So we started home therapy. She was progressing well, but with rejection, her exercise capacity came down. Now it's picking up again. So the precaution, we should avoid arm abduction, arm ergometry during the first 4 to 6 weeks. Anything that precipitates pain, you need to be careful. Pushing, pulling exercises, weightlifting, more than 2.5 kilo weightlifting for first 4 to 6 weeks, it's better to avoid. The complete healing takes 3 months, but sternal precautions we advise for 6 weeks. So use of walking aids for energy conservation, as I said. So avoid arm ergometry, pushing, pulling exercises that can stretch the incision and affect the sternal stability. For the sternotomy and anterolateral sternotomy, thoracotomy. So the goals in the step down or ward, once the patient shifts to ward from ICU, the goal is to wean off the tubes. Some of them might be on tracheostomy, urine catheter, and feeding tube. All this we need to remove one by one. So your aggression of your therapy definitely helps. How well you mobilize, how well you clear up the secretions for the pulmonologist. So assess the oxygen requirement. While you are exercising the patient, definitely assess the oxygen requirement. You are there with the patient when they are mobilizing. So that is an excellent time to assess the capacity of the lungs. So you will be able to guide them how fast to wean off the oxygen. Educate, you can start mobilizing even with the CPAP. When they are still on the CPAP, we make them walk by PAP. Educate the patient and family on care at home. Start education early enough. So when we can split the goals into PT, OT, psychology goals, PT can work on improving endurance, strength, walking distance. They ask, the suggestion is to start with 100 meters and gradually increase it. Sitting out in the chair 3 times a day, gradually increase to 5 times a day. So finally, they should be able to climb stairs if it's a good candidate, uncomplicated transplant. They should be able to climb the stair prior to discharge. So encourage independence in ADLs. At the same time, you should encourage them to eat by themselves, dress, groom, brushing their teeth and all, do it by themselves. Otherwise, they'll end up depending on the carer for their lifetime. So for a few months at least. All this helps in improving the upper limb strength and endurance. So assess the cognition and mood. hospital anxiety depression scale is a very good scale which the psychologist can use before prescribing the antidepressants. One of our patients had depression. We tried antidepressants, but she had a obstructive sleep apnea like thing with the antidepressants, and we had to readmit her with the worsening of saturation. So be careful when you start antidepressants. Do a hospital anxiety depression scale and then start it. Nutrition, the dietitians need to really take care. Low potassium, healthy, low cholesterol, all those things. And also strictly ask them to avoid outside food because it can cause the GI infection. Probiotics are better avoided. All this the dietitian need to take care. So this is an excellent article, which is, as I said, is freely available online. So the intensive care unit, they have given specific progression, how to progress. Bed mobility, dangling, transfer to chair, standing, marching on spot, ambulation with the walker. So this is the second one, step down unit, or what? This is what I said. 1 to 3 times up to chair, 1 to 3 times a day, supervised walking, 1 to 3 times a day, build up to once a day, 100-meter walking, progress to 4 to 5 times mobilizing to chair. So like that, it gives a proper idea of how to progress. So this is another patient who is in the ward, who has been transferred to the ward from the, she is 3rd week post-op. She's getting discharged. So we are doing a 6-minute walk test. She is stable enough. He's just keeping the hand for safety. She could walk for 143 meters. This is her climbing stairs. She had a long time waiting for a lung. She was not affordable, so she was essentially registered with some other center. She had the 2 years of waiting. She was restricted to a 1 room inside her house, which is on the 1st floor. She would never come out of that room. And rehab, we tried to push, but she was not. There was not enough support to bring her to the therapy unit. So when she had the donor call, she came along with her 11-year-old daughter. So we had to crowdfund for her surgery, but she did well. And for those patients who are like this restricted to single room, we need to think about bone protection. They are at high risk for fractures. And on top of the low vitamin D, they will have this steroids worsening the osteoporosis. So make sure you educate them on spinal precautions, sitting straight, avoiding stooping, avoiding the twisting movements. In case they report any spinal pain, take it seriously and investigate. So avoiding lifting weights, at least for the first 6 months till it regains the strength. So the goals for subacute rehab, 1 to 6 months, it's mostly to after discharge, it's to intensify the program. Same strength, endurance, balance, breathing exercise, everything you need to intensify. Also, you need to detect infection or rejection because you will be in constant contact with the patient. So infection, you need to understand what are the signs of infection, what are the signs of rejection. All this you need to be aware about. So the same as rehabilitation, the frequency, intensity, type, timing, progression of the exercises you should be aware of. Start with light intensity and light intensity in the perceived exertion scale, and increase to somewhat hard level. That is the 3 to 4 level. You can increase the board scale. That is, they should be able to carry out a conversation in short sentences without feeling too puffed. That is the level that we want. It should not be too easy for them, and it should not be too hard for them. So they should not feel too breathless at the same time, but they should be able to talk to you in short sentences without puffing, but they should feel the increase in heart rate and respiration. So educate them, warm up, cool down, because the denervated heart takes a longer time to reach the required levels. So slow walking is a good warm up. Maintain exercise diary. This is very important. Then only we will know how much we exercised the other day. So educate them to maintain an exercise diary. Stop temporarily in case of infection or rejection, and then you can start from the basics again. So this is again from that literature, the exercise capacity assessment. So We need to assess the exercise capacity. There are lab-based tests, the CPET machine. You can use the simpler 6-minute walk test or the shuttle walking test. We need to assess exercise capacity, muscle function, physical performance, and physical activity. Muscle function is the manual muscle testing or dynamometry. Physical performance is the gait speed, the timed up and go balance scale. All this gives the physical performance. Physical activity is the how active the patient is at home. Nowadays, all of them have Android mobiles, which will show the step counts. The target should be from around 2,000 steps minimum. So slowly they need to increase the physical activity. This is in the first 1 to 6 months. So this is a patient that we had on the discharge stage. So this is one who was on anti-anxiety drugs. She looks a bit tired and the oxygen was tending to drop. So we had to start the rehab program after she got discharged the second time. So she is better and walking a bit better with less pain. She had an infection flare-up, that's why she was admitted again. But she is recovering. This time we will be reporting her with oxygen support because of the infection flare-up only. She's off oxygen and taking exercise now. So the 3 months home program, there is a study which compared the patients who attended the rehab compared them with the controls who didn't attend the rehab program. So it showed significantly better results with the quadricep strength, 6-minute walk distance, and daily activity. So exercise training after lung transplantation improves participation in daily activity. This is a randomized control trial. Precautions during subacute rehabilitation, again, worsening of exercise tolerance could be a sign of rejection. You should keep in mind that exercise tolerance coming down could be a sign of rejection. So infection control, take care of your hand hygiene. Don't go near the patient in case you have an upper respiratory infection. Make sure you address the activities of daily living, eating, bathing, grooming, all this are outcome measures. You can use the 6-minute walk test again. You can do a baseline one, repeat it at 3 months, 6 months, and 1 year interval. FIM score is the functional independence measure. If the patient, it takes care of multiple areas, the OT, physio, and speech areas it will cover, and see how independent the patient is functionally. That is a rehab outcome measure. Long-term goals is community reintegration. Long-term, we look at community reintegration, and at the same time, we should ensure that the patient is doing maintenance exercises. The only way to ensure is that to keep them as physically as active as possible, encourage them to return to work, return to leisure activities. Return to driving is after 6 to 8 weeks, once they are off the sternal precautions. Return to work is after 4 to 6 months, once their chance for rejection comes down a little bit. And leisure activities, they can, depending on how intense it is, they can start from 6 to 8 weeks, but avoid contact sports which can harm the lung. Holidays better planned after 1 year, and talk to your doctor about immunization prior to returning to, prior to going for holidays. So the pulmonary embolism, all these complications can happen post-op. So keep an eye for the open for DVT and all when you train them. And the most another important thing is the 3 most important muscles that is needed for standing is, as you know, the hip extensor, hip abductor, and knee extensor. When you do the lower limb strengthening, concentrate on these 3 groups, and ankle plantar flexors will help with the push-off phase. So if you are making them walk, that will help. So this 4 main groups of muscles you can concentrate. Upper limb will help with endurance. So the take-home message is goal-oriented training is needed at each stage, and know the precautions and the principles, and know what you're doing. There should be high suspicion for rejection or infection, and make sure you don't give infection to your patient, and no need for expensive technology. For 6-minute walk test and the dynamometer and the usual exercise equipment is enough. What we make the patients buy is a weight cuff. We make them buy at home. Weight cuff, TheraBand, and simple sitting pedal cycle is available. Pedal cycle costs only 1,500. We started during the rehabilitation phase itself and continue as post-op also. So with that, they can do the endurance training. Thank you.
Thank you, ma'am, for the nice presentation, and happy to see your transplant patients also walking without oxygen. And I think the post-transplant rehab, I think it's a totally different challenge as compared to the pre-transplant rehab in many aspects from your presentation. So one few doubts is that, ma'am, in your post-transplant, most of the patients are very worried about doing an upper limb exercise. So just wanted to ask your opinion about, can they perform the upper limb exercises after transplant, or you want them to wait for some weeks, or what's your take on that?
Yeah, usually upper limb exercise, there are precautions, especially arm ergometry, they say to avoid pushing, pulling. This overhead stretching will anyway stretch the incision. No? So any stretch to the incision will precipitate the pain. That's what I feel. Pain is very important factor when you consider deep breathing exercise. If the pain is bad, you can't breathe deeply. I've seen patients going into type 2 respiratory failure with a rib fracture, elderly patients. So you need to consider that. It's a very painful incision. So it takes 3 months to heal fully, but at least for 6 weeks, if you can avoid or restrict, at least do one hand at a time. Like that, you can try. And this pillow assisted directed coughing is really good. With some assistance to the abdominal muscles would help to really clear the secretion, especially if they are on tracheostomy. We see that often with the spinal cord injury patients, their diaphragm is paralyzed, their cough will be very weak. What we do is just give a pressure thrush at the epigastrium or the rib sternal cage. When they doing the expiration of the expiratory phase of the cough, along with that, they should give the pressure. So that the cough expiration is stronger. That really helps to clear the secretion. And if you can lower the head end a little bit as tolerated, and after discussing with your pulmonologist, that helps with a little bit of postural assistance also. So idea is to give same as the old pulmonary rehab. Nebulizations will help to thin out the secretion. Then vibration will help it to fall inside the alveoli. Then the postural drainage along with the expiratory assistance will help to clear the secretion. If that is achieved in the initial period, then it will be a lot more easier to bring them out of the ICU.
Sure. And one other thing is that, do you have any goals prior to discharge from a rehabilitation point of view, like whether we should shift to a rehab center or whether they can go home?
Yes. As that study was pointing out, there are two kinds of patients. One is uncomplicated. They can go home straight away. If they're climbing stairs and all, they don't have to. If those complicated patients who had a longer ICU stay, but they have come up to the BiPAP level, at least. So that is the criteria for going to a rehab center. So rehab center, if you have a multidisciplinary rehab center with good setup and a doctor's input is definitely needed, a rehab consultant or somebody who critical care who manages the rehab unit, where there is intense physio. We do at least minimum 3 hours of therapy the patient gets there. So that helps to retrain the muscles. Physio will take care of mobility. OT will take care of this daily activities and hand function, pacing of activities to return to their normal life. Speech will take care of decannulation plans, follow-up assessment. So we do weekly meetings to assess the progress along with the family. We take care of, educate the family on how to take medications, how to properly time it and do it by yourself. So one of our patients, that lady that last week showed, she took a medication at 7 o'clock, tacrolimus, and her daughter-in-law thought that she didn't have it and gave an extra dose of tacrolimus at 9 o'clock. So all this can happen. So all this, if it happens when she is admitted, it's safer. That is the advantage of going to a rehab center.
Thank you. Any questions from the audience?
Sir, can I ask one question to ma'am, sir?
Yes, please go ahead.
Ma'am,
Yeah, please ask me.
ma'am, while progressing the exercise sessions, will you be considering the VO2 max or means maximal heart rate while improving the strength and endurance levels, ma'am? You'll be calculating the VO2 max, ma'am?
We don't have the CPAP machines, ma'am.
You'll be calculating, ma'am?
No, we don't have the CPAP machine.
Okay,
Only
okay.
the 6-minute walk test.
Only criteria. Ma'am, will that be fine? 6-minute walk test?
6-minute walk test. You need to assess the walking speed.
Okay,
from the
ma'am.
distance, we need to assess the walking speed and start with 75% of that walking speed.
Okay,
and
okay, fine.
100% and then progress up from there.
Okay, no need to, no, it's not mandatory to go with VO2 max.
No need.
Okay.
Even the international protocol suggests this only.
Okay.
Before. So the 6-minute walk test, then you can suggest ball scale is what they mainly consider. The start with light intensity, progress to moderate to hard, somewhat hard they should reach.
Okay, ma'am. Okay, ma'am.
11 to 13 in the rest.
Sure. Okay, ma'am. Thank you, ma'am. Thank you, ma'am.
Any questions is there? Okay, I think somebody has raised the hands. Ma'am, please go ahead and ask your question. I think one of our audience want to ask a question. Ma'am, I think you are not audible. Or if you are not able to ask, you can even write in the chat box. That's also fine. So in the meantime, sir, hello.
What is the reason for sudden complications post-surgery? Is that the question? What is the reason for sudden complications post-surgery? Newton Praveen. Sudden complications could be pulmonary embolism if you are not taking care of the DVT and all. Pulmonary embolism is quite common, and we need to make sure that the breathing rate, if it goes up, really unmatched as before. If the heart rate is too high, saturation suddenly starts dropping, keep a high suspicion for pulmonary embolism. And acute complications, immediate post-op, as any other surgery, all these complications can happen. Infections can happen. Especially for transplant, there can be the primary graft dysfunction or acute rejection. If the rejection lasts as a chronic one, it becomes more difficult. So all this, any complications that is expected with a normal surgery can happen here also. Effusions can happen. Pulmonary edema patients might have fluid inside the lung, which will take longer to resolve. The lung is healing after such a major and re-expanding to adjust to the new pleural space. So there can be effusion. So we need to auscultate and see that there is no, they are not going into pulmonary edema. Pleural effusions can happen. If the exercise tolerance is coming down, oxygen level is dipping, you need to alert the pulmonologist to look for all this. So it's a constant handing over, and it's a team approach. So even if you feel that it's a silly question, just feel free to ask to the pulmonologist. So it's okay, because patient safety matters at the end of the day. So don't shy away from asking questions, and don't make sure you alert your pulmonologist in time or critical care persons in time.
Any more questions? Is there? I think, as Madam said, I think three most common things are like that infection, graft dysfunction, and the pulmonary embolism. However, there are many other issues like pleural effusion that gets infected and multiple other things. Yeah.
And delayed wound healing.
Yes.
This can happen.
So just one, I think one other person is asking, but I think it's not audible. So in your point of view, ma'am, what determines the success of rehabilitation, especially post-transplant?
Post-transplant should begin early within the ICU itself, making sure that we save the patient first of all as a team, and then it is maintenance. Maintenance is a little bit more easier when compared to pre-rehabilitation because we have a better lung to deal with. So once you save the patient from the ICU unit and bring them out of it, and then it's retraining the muscles. Muscles will take long to heal, but the lungs, we have the better lungs now. Muscles will take years to heal. So assisting it 4 to 6 months, it needs intense training.
Same with Suman sir. Sir, what determines success of rehabilitation, especially in a pre-transplant? Because in pre-transplant, challenges are slightly different and many other hurdles are there. So according to you, what determines the success of rehabilitation in the pre-transplant period?
Sir, success, as I said, as I mentioned earlier, sir, adherence towards the exercise is the main key, sir. So most of the people, sir, they don't adherence with the exercise, and as you mentioned earlier, they want to get to know everything about the exercise. Just you teach in one session, we'll go in home and we'll do. So the first they need to understand their capacity, and they need to overcome their fears. So they need to adherence towards exercise, and they need to understand when they have to go with an endurance, when they have to start with an interval level training, when they have to progress to the resistance training. So with all these things, only the key of the success of rehabilitation will be expected, sir. And it's mandatory. They need to follow up with us till minimum 6 weeks, sir. Before 6 weeks, they can't expect any good outcomes, sir.
Yes. Sure. I think there are no more questions. So thank you all for joining, and it was a wonderful session, and especially about the patient guidance and what are the usual barriers we have discussed about. So thank you all for participating, and good night.
Good night, sir.
Thank you.
Good night, ma'am.